Hello, everyone, and welcome to the Digital Health Wire show. My name is Jason Barry, and I'm the editor of Digital Health Wire and the host of the show. Today, I am joined by Dr. Holly Miller of MedAllies, and we're going to be talking about TEFCA, interoperability, and all the wonderful new use cases that bringing more data into kind of the healthcare ecosystem is enabling for everyone. So, Dr. Miller, it's great to have you here.
Thank you, Jason. I really enjoy being here and having you ask me these questions.
I'm looking forward to the conversation.
Me
Um,
too.
Before we dive too much into all of the acronyms in the alphabet soup here, why don't you kind of walk us through your role and the path that brought you to MedAllies and the work that you're currently doing?
Well, I'm an internist, which is a primary care physician for adults. And when I practiced, that was what I was doing. And initially, way back early on in my career, I was working for an organization that had a homegrown electronic health record system. And by today's standards, this system was truly, utterly terrible. But immediately, I realized that they had EHRs had tremendous potential to to do better medicine for the population. So I was kind of treating one patient at a time, which was very satisfying. But at the same time, I saw the opportunity to really make a broad impact. And that's why I became interested in health information technology.
Fantastic. And as it within your current role, can you kind of walk us through what you're spending a lot of energy on, what you're excited about, and like the big problems that you're trying to solve?
I am the chief medical officer at MedAllies. And so a lot of what I do is very practical. So if there are work that we're doing that requires a physician input, that will be me. Often I am in charge of some of the pilots that we do so that we can make sure that we're testing things out, that there's adequate communication with the groups that are working on the pilot, and most importantly, including those clinicians in an organization that might be bringing something live, working with them to make sure that they've identified role-based workflows, everyone is trained, and that they're optimistic about what they're doing and what it might bring to them and their organization.
Perfect. And so it's been an exciting year for interoperability in general, it seems. TEFCA, the TEFCA Go Live has officially happened here. Can you, no better person to ask about, I would give the audience an intro to TEFCA, but I'll hand the microphone over to you to kind of just give us the mile high view of what TEFCA is, why it's exciting, and what are some of, we'll start with that before we go any deeper.
So TEFCA really is stands for the Trusted Exchange Framework and Common Agreement. So hopefully we'll have a chance to get into that a little bit more. But TEFCA actually was created as part of the 2016 21st Century Cures Act. And it's different than what we've done in the past. It really is meant to be the on-ramp for all healthcare constituents to interoperability. And you'll hear these phrases turned around, used frequently, the on-ramp for interoperability. I particularly like the Internet of Interoperability. So if we imagine how we use the internet now for communication, for searching for things, for having people send us, it really could be that for healthcare information.
So are we currently, as it stands, we have some of the QHINs live, the Qualified Health Information Networks. Are we in the internet era of the 80s, the 90s, 2008, when the social media platforms were coming? Where do you think we are as it stands today?
Well, this is why I'm so optimistic about TEFCA. And just, I don't think we've identified that acronym. So can we go there for a minute?
Please walk us through
Uh-huh.
what is a trusted exchange framework first and foremost, and then we'll move on to the second half of the acronym.
So I think the Trusted Exchange Framework really is talking about the infrastructure and building out a an agreed upon established infrastructure that all of the participants are going to follow. The second half of that is a common agreement. And in order to talk about TEFCA, we really should talk about the recognized coordinating entity, which is Sequoia.
Mm-hmm.
And Sequoia was assigned by ONC that role. And one of the things I really appreciate about the Sequoia organization in general is that they're very good at pulling together leaders in thinking and leaders in the industry to create various things that they do, but that to establish, in this instance, they used a broad call for industry experts and really for many to get involved in creating that common agreement. And so these are, and I like this analogy for some reason, but if we think of the trusted exchange framework as building our superhighway infrastructure, the common agreement is really the rules of the road. And that in order to participate, you have to follow these rules of the road. And I think that's part of what's very exciting, is that we now will have a exchange framework and common agreement. And part of, again, the exchange framework will be a directory that will enable one organization to find information on a particular patient anywhere in the United States.
How does TEFCA differ from some of the existing information networks that were already in place, and that I think most provider orgs, correct me if I'm wrong, were already participating in some form of information sharing prior to TEFCA? What are some of the finer points that really differentiate TEFCA from the existing ways of doing things?
Jason, this is something I could literally address for an hour.
Please, we can chop it down later.
But to be brief, I think in the last many years, various networks have come into play. And I think that the first work that was done on a framework, if you will, was around direct. And the direct trust was created for the direct protocol that was a mode of exchange. And so at that time, MedAllies was very actively involved, and we continue to operate one of the, in my opinion, very best health information service provider networks within that framework. The other things that happened were networks started to be created. For example, Epic created what's called Care Everywhere, which was phenomenal because if you're on Epic, you could get information about a patient on any other Epic network. Now, my husband's a surgeon, and he has Epic. He works at the Cleveland Clinic, and they use Epic. And he will tell me that it's so strange because sometimes when I'm getting a referred patient, I have all the information I need about them, and other times I get a fax. And he doesn't, as a clinician, he doesn't get that if you're not on Epic, you're not going to get that information through the Epic Care Everywhere network. Similar networks were established for other EHRs that came together to build a network, but none of these were really under a framework other than direct. And then care equality became the second, what I would call framework, that included care quality implementers that were the networks. So the networks are really the point-to-point connectors. But when I say that, it can be, they will communicate with each other very actively to get the required information. So it's any endpoint and we're hoping in TEFCA that it will be any endpoint or any entry point for an organization to sign up with a QHIN. They will then have access to any endpoint that's signed up with a QHIN. So I think this is incredibly exciting.
Can we actually take a minute to backtrack and dive into what is a QHIN? That's an acronym that we keep throwing around. Let's talk about what a QHIN is and who can be a QHIN, who is already a QHIN, and go from there.
Terrific. So for the trusted exchange framework and common agreement, we talked about that being the infrastructure, agreed upon infrastructure that needed to be built, as well as a common agreement, which is the rules of the road that everyone would follow that participates. The qualified health information networks, or QHINs, are the networks that have been designated by the RCE to become the on-ramp for healthcare organizations or any constituent in healthcare that has a reason to be receiving or sending information, making that electronically accessible. And the wonderful thing is that the kind of the phrase that we use is accessible health information without special effort on the part of the user. So ideally, this information is going to be in the electronic health record, just like it would be coming from inherent to the electronic health record. But we have some work to do on that.
And is there who can access this information? Is it only network participants? And is there any sort of reciprocity where they share clinical outcomes or anything like that back into the network to kind of feed it forward, if you will?
Well, I think that's a very important question because I mean, we're all at some level healthcare consumers. And so what is the security around my data? Am I really giving permission for it to be used? And I think this is an important question as we go forward to think about. And so as part of the common agreement and trusted exchange framework, what has happened is that they've designated purposes of use. And they've designated under those purposes of use the constituents with a legitimate purpose of use that can access the data they require. So in order to do this, you have to be a constituent in those that has a reason to get the data that is already included in one of the defined purposes of use, and that you are signed into the common agreement and you're going to follow the rules. So the current purposes of use are treatment, individual access, and that's one that I particularly love because that means consumers can access and aggregate and distribute their own data as they want, using whatever application or app that they choose. Another purpose of use is public health, benefits determination, and a subset of the HIPAA-defined payment activities and a subset of the HIPAA-defined healthcare operations, for example, quality assessment and improvement, business planning and development. And the important thing is that, again, Sequoia, the RCE, has said that these will evolve, and they'll evolve with guidance through the framework governance. So TEFCA already has a representative governing body, and in that governing body, there are both representatives from networks and the network participants. So those endpoints that we were talking about that are in the QHIN.
Now that TEFCA is operational, what are some of the new use cases that we can be excited about that it enables for these different purposes of use that we didn't necessarily have access to before? You mentioned being excited about individual access. Are we close to a world where a patient can maybe sign on with a new provider and bring their entire medical history with them through a TEFCA supported backbone?
That is exactly one of the things I hope for. I hope that certainly even without TEFCA, because that the new provider could query for a treatment purpose and get all the information across the country. But I also look forward to the ability for consumers to provide input to their data. For example, I'm not taking that medication anymore, and to have that be available to their providers as they edit things. The other thing that I find particularly exciting is that there are some applications or apps that provide services beyond what we have experienced to date. For example, if a consumer has a specific diagnosis, and for example, a cancer diagnosis, there's an application that can provide that patient with information about the various treatments and even the experimental treatments that are ongoing that they may want to participate in. So that's an area that I think there's huge potential as things evolve. The other thing that can be so time consuming for an office is and again, this isn't there yet, but I'm hoping that we can evolve to this, is both benefits determination and pre-approval. So what does it take to get prior authorization for a procedure or a test or something that the clinician needs to find out from the payer whether it will be covered, so they can honestly tell the patient what it might cost them or what's involved.
A huge portion of the digital health wire audience is actually at health systems and at provider orgs. If we zoom in on the benefits specifically for those working at hospitals or patients getting treated at a health system, how has TEFCA already impacted provider workflows, the quality of care, and things like that?
Great question. So and that's a multi-layered answer. So I'll start with a few things. And I think the first thing that I should mention is often when I was practicing, patients would bring in a tome of information, and I have 15, 20 minutes for the visit if it's a new patient to me. And so going through 150 pages of faxed or photocopied or faxed information just wasn't possible. So think about data coming into my own system. And at the time I was using an electronic health record that I had to input the data because it wasn't coded data. It wasn't data that had been interoperably exchanged. But when we think about data that's going to be interoperably exchanged, ideally, it is standardized coded data that is both human readable and machine readable. So as it comes in, the system that's receiving it can assign the same exact meaning to the data that the sender sent. And the benefits, and let me first start with the benefits for patients, that the idea that that might dramatically decrease medication or any kind of medical error. It will also, for society, dramatically reduce costs, as the information about tests the patient has had and studies will already be in there, so that we won't need to duplicate those things. But also think about the time and sometimes pain involved with getting those tests. So it'll for consumers of healthcare, it will greatly enhance their time and their ability to manage their disease and not have to repeat things that they've already done that would be time consuming and potentially painful for them.
It's easy when you paint such a beautiful picture of all of the benefits of interoperability writ large or with TEFCA, to kind of be a blind evangelist of the whole system and the framework. Is there anything that you think is a blind spot, or like something that are there any drawbacks to it, like to round out to make sure that we're being fair to the entire argument? Are there any downsides to TEFCA, or did we find the free lunch in healthcare finally?
I love that. I think one thing that everyone has to realize is, so the downside of, and I'll say interoperability, currently is ensuring that the data is usable. And when we say usable, there are a variety of aspects to what, for me, that means. I referenced an unclassified tome of information that cannot be absorbed. Making data usable includes things like ensuring that the codes are standardized and recognized, so from one machine to the other, they can be understood. It also includes eliminating duplicates. I
Mhm.
think some of the other things that are so important are the provenance, or where did the data come from? Who first prescribed this medication? Oh, a
Mhm.
specialist prescribed it. And then it was refilled by the primary care physician. And then the dose was eventually changed by someone else. And so when that information comes in, that you can track a data element and how it's evolved, or who wrote it, who put it into the system, and how valid is it?
Mhm. And as we kind of follow this path forward to where we're going, from where we are today to where we're going, do you think it's a possibility to achieve that holy grail of a national patient ID or a national patient record that's on tap for any provider, for any patient with proper use cases? Is that something that we should be striving for, that's achievable? Or is that even the end goal of something like TEFCA?
I think that's a terrific question, and I have to answer that I absolutely think it's an end goal. I absolutely think it's doable, and we have only to look at some of our European neighbors to understand how successful a single ID has been.
Mhm.
Um, in many countries in Europe, they are using a single ID across uh, the healthcare. And for one, trusted in the trusted exchange framework, or TEFCA, the T is for trusted, one of the most important aspects of that trust is knowing that the information that I've just put into my electronic health record for patient ABCD is truly patient ABCD and not patient ABCDE,
Mhm.
so that I can trust that I have the right information for the patient that I want to be treating.
I look forward to that day that I can use my own complete health record anywhere at any time. Is there anything about TEFCA that you feel that most people either get wrong or don't even incorporate into their thought processes when they're thinking about the issues that it's solving or the problems that it's addressing?
Great question again. And I think I've already kind of referenced this, that sometimes, and Jason, I'm sure you've heard of a hype cycle.
Hmm.
So with the
Once or
hype
twice.
cycle, often people just think it's going to be overnight. This will be the solution. But we are definitely in a situation where we need to crawl, walk, and run. And so it's going to take some time. But I do believe that TEFCA will succeed as the predominant interoperability framework.
Hmm.
And so maybe not getting wrong, but having a preconceived expectation that this is going to happen in 6 months, a year, is just not the case. It's going to, we need some time to have folks adopt this and understand this.
You're so close to these issues and you're so close to you have such a better understanding than myself of the kind of background and the infrastructure that it actually takes to make all this happen behind the scenes. Is there anything that you've learned or changed your mind on recently as TEFCA has been progressing over the last year, particularly, and even before that?
Well, first, I'd like to set the record straight. I think you have a great understanding of this.
I appreciate that.
I think your questions reflect that. I think you've done a lot of work researching this, so I've been impressed with your knowledge base.
Oh, hey, I'll take it. I'm not immune to flattery.
Um, that being said, one of the things that I greatly appreciate is when HTI-1 final rule came out, that algorithms that are sold are going to require review. And I don't know yet. I don't think ONC has yet announced exactly who will be involved in that, how it will take place. I do know that ONC is the office that will be putting that together. But to me, that's very reassuring, because we do know that there have been algorithms that have been developed that might be discriminatory or uh, incorrect, and so having a expert review and ensuring that discrimination and quality is the case, I think that's fabulous. And I think it's a real protection for consumers.
Although I am the furthest thing from an AI expert, when I picture all of the vendors and providers that will want to be running AI models on top of this awesome tome of data, is I'm picturing so many people, so many models, and models that are so continuously updated that I have a hard time wrapping my head around a trusted expert reviewing all of that. Can you kind of connect that dot for me on how that's even remotely possible?
So, Jason, it's not everything. It's really the healthcare algorithms.
Mm,
So, and this is probably a very poor example, but it's the one that popped into my head, determining the risk or the identifying who needs a kidney most,
mm,
and which would go into consideration of the list and the placement on the list for kidney recipients. So to make sure that that's non-biased, to make sure that everyone is just as eligible that requires a kidney as anyone else. I think that's very important. So it's not all the other things. And I think there are some things very exciting that artificial intelligence could bring to us. We are, as clinicians, so overwhelmed with data and so overwhelmed with the rapidity with which we need to treat patients, that anything that can help us kind of pull together the information we truly need to be having right in front of us at that moment is going to be useful. And that's something I think AI can do.
Well, I'm excited that we're at a point where we can even be having a conversation about a national patient ID. And TEFCA is haptic. You can reach out and touch it. You can participate in it. Holly, thank you for walking us through all of this and sharing your excitement about the topic with myself and with the Digital Health Wire audience. I really appreciate it.
Well, Jason, it's been a real pleasure talking to you. I greatly appreciate the opportunity to have had this conversation. It's been a lot of fun.
Yes, it has. All right, everyone. That's been the Digital Health Wire show. Thank you for joining us, and we will see you next time.